Hello, dear student. Today we are continuing gastroenterology, and in accordance with rules the prevention of coronavirus, lecture were transferred online. And please leave your name, surname, and number of group under this lecture. And after this lecture, if you will have questions, please leave your comments too on the lecture. Okay, let's start. And topic for today and name of this lecture: Gallstone disease, chronic cholecystitis, and functional biliary disorders. All about bile secretion and composition. Bile formed in the hepatic lobules is secreted into a complex network of caniculi, small bile ductals, and larger bile ducts, then run with lymphatics and branches of the portal vein and hepatic artery in portal tract situated between hepatic lobules. These interlobular bile ducts coalesce to form larger septal bile duct that join to form the right and left ducts, hepatic ducts, which in turn unite to form the common hepatic duct. The common hepatic duct is joined by the cystic duct of the gallbladder to form the common bile duct, which enters the duodenum through the ampulla of water. Hepatic bile is an isotonic fluid with an electrolyte composition resembling blood plasma. The electrolyte composition of gallbladder bile differs from that of hepatic bile because most of the inorganic anions, chloride and bicarbonate, have been removed by reabsorption across the gallbladder epithelium. As a result of water reabsorption, total solute concentration of bile increases from 3-4 gram on deciliter in hepatic bile to 10-15 gram on deciliter in gallbladder bile. Major solute components of bile by moles percent include bile acids 80%, lecithin and traces of other phospholipids 16%, and uninterfeed cholesterol 4%. In the litogenic state, the cholesterol value can be as high as 8-10%. Or other constituents include conjugated bilirubin, proteins, electrolytes, and often drugs and other metabolites. The total daily basal secretion of hepatic bile is 500 to 600 milliliters. And three mechanisms are important in regulating bile flow. At first, active transport of bile acids from hepatocytes into the bile caniculi. Second, active transport of other organic anions. And third, cholangial cellular secretion. The last is a secretin-mediated and Colic APM-dependent mechanism that results in the secretion of a sodium and bicarbonate-rich fluid into the bile ducts. Cholesterol catabolism by hepatocytes results in the synthesis of the two major primary bile acids, cholic acid and chenodeoxycholic acid. This process involves multiple steps with cholesterol as alpha hydroxylase acting as the rate-limiting enzyme. Primary bile acids undergo dehydroxylation by bacteria in the small intestine, forming the secondary bile acids, deoxycholic acid and litholic acid, respectively. Both primary and secondary bile acids are conjugated by the liver with an amino acid, either glycine or taurine. Conjugated bile acids are known as bile salts. Bile salts inhibit cholesterol 7-alpha hydroxylate, decreasing the synthesis of bile acids. And continue about the main step in the formation of bile are the uptake of bile acids and ions from plasma across the basolateral membrane, transport through the hepatocyte, and expression via the Carnalicola membrane. And about basolateral membrane. The sodium-potassium ATPase of the basolateral membrane of the hepatocyte maintains sodium and potassium gradients. Because 3 sodium ions are expelled from the cell in return for receiving 2 potassium ions, and an electrochemical gradient is formed. The relative negative charge inside the hepatocyte favors the uptake of positively charged ions, while the sodium gradient fools the sodium-dependent taurocholate co-transporter protein. This transporter allows for the uptake of conjugated bile acids. Next step, Carnalicola membrane. The transporter proteins found in the Carnalicola membrane are primarily members of the ATP-binding cassette protein family. These proteins use active transport to secrete molecules and enzymes into the bile. The Carnalicola membrane transporters help secrete molecules into bile against concentration gradients, and also enzymes such as alkaline phosphatase. Contractive microfilaments facilitate the secretion of bile through the carnaliculae. You may see table with diseases of the gallbladder, and for example, cholelithiasis. And what is it? Cholelithiasis is microscopic crystals or large stones in the gallbladder. Next disease, cholecystitis. Cholecystitis is inflammation of the gallbladder. Next, cholelithiasis is common bile duct stones. Next, biliary dyskinesia, motility disorders of the gallbladder caused by scarring or spasm of the sphincter of Oddi. Next, gallbladder perforation. And what is it? A hole or opening in the wall of the gallbladder, and maybe acute, and acute is generalized biliary peritonitis. Subacute combine acute plus pericholecystitic abscess, and chronic cholecystoenteric fistula. Next disease, Gallstone pancreatitis, is inflammation of the pancreas caused by obstruction of the pancreatic duct by a gallstone. And last disease, gallbladder polyps. And what is it? Overgrowths of all lesion in the gallbladder wall. And what about cholecystitis? Cholecystitis is defined as an inflammation of the gallbladder that occurs most commonly because of an obstruction of the cystic duct from cholelithiasis. 90% of cases involve stone in the gallbladder, with the other 10% of cases representing calculous cholecystitis. Gallstone disease is very common. About 10–20% of the world population will develop gallstones at some point in their life, and about 80% of them are symptomatic. And cholecystitis divided on two variants, acute cholecystitis and chronic cholecystitis. And what about acute? Acute inflammation of the gallbladder wall usually follows obstruction of the cystic duct by a stone. Inflammatory response can be evoked by three factors. First, mechanical inflammation produced by increased intraluminal pressure and distension with resulting ischemia of the gallbladder mucosa and wall. Second factor, chemical inflammation caused by the release of the lysolecithin and other local tissue factor. And third factor, bacterial inflammation, which may play a role in 50–85% of patients with acute cholecystitis. And what about chronic cholecystitis? Is chronic inflammation of the gallbladder wall is almost always associated with the presence of gallstones, and it true to result from repeated bout of subacute or acute cholecystitis, or from persistent mechanical irritation of the gallbladder wall by gallstones. The presence of bacteria in the bile occurs in more than 25% of patients with chronic cholecystitis. The presence of infected bile in a patient with chronic cholecystitis undergoing elective cholecystectomy probably adds little to the operative risk. Chronic cholecystitis may be asymptomatic for years, which may progress to symptomatic gallbladder disease or to acute cholecystitis, or may present with complications. Okay, and on this picture you may see what happened with patient when have acute cholecystitis or chronic cholecystitis. Okay, etiology. Chronic cholecystitis mostly occurs in the setting of the cholelithiasis. The proposed etiology is recurrent episodes of acute cholecystitis, cholecystitis or chronic irritation from gallstones invoking an inflammatory response in the gallbladder wall. Sometimes the term is used to describe abdominal pain resulting from dysfunction of the emptying of the gallbladder. This overlaps with sphincter of Oddi dysfunction and is best referred to as biliary or gallbladder dyskinesia. Risk factors for cholelithiasis include female gender, obesity, rapid weight loss, pregnancy, advanced age, and Hispanic or Pima Indians. Pathophysiology. Gallstones by causing intermittent obstruction of the bile flow, most commonly by blocking the cystic duct, lead to inflammation and edema in gallbladder wall. Occlusion of the common bile ducts such as neoplasm or strictures can also lead to stasis of the bile of the bile flow, causing gallstone formation with result chronic cholecystitis. It has been proposed that lithogenic bile lead to increased free radical mediated damage from hydrophobic bile salts. That in association with reduced mucosal protection due to lower levels of prostaglandin E2 results in a continuous inflammatory state. When the cholecystokinin receptor or the smooth muscle are affected, there is impaired gallbladder contraction that lead to stasis and warns the permissive environmental where lithogenic bile promote inflammation. Cholesterol. Gallstones are mainly composed of cholesterol that has solidified. Pigmented gallstones are usually calcified and contain different types of pigments, and so its name. Stones can be as small as a grain of sand and as large as a gold ball that can even get to encompass the entire cavity of the gallbladder. And you may see type of gallstones on this picture: pigmented or calcified gallstones, cholesterol gallstones, and combined those two variant, and patients have mixed stones. And continue about pathophysiology. Cholesterol gallstones. More than 80% of gallstones contain cholesterol as their main component. Liver cells secrete cholesterol into bile along with phospholipids in the form of small spherical membranous bubbles termed unilamellar vesicles. Liver cells also secrete bile salts, which are powerful detergents required for the digestion and absorption of dietary fats. Bile salts in bile dissolve the unilamellar vesicles to form soluble aggregates called mixed micelles. This happens mainly in the gallbladder, where bile is concentrated by reabsorption of electrolytes and water. Compared with vesicles, mixed vesicles have a lower carrying capacity for cholesterol. If bile contains a relatively high proportion of cholesterol to begin with, then as bile is concentrated, progressive dissolution of vesicles may lead to a state in which the cholesterol carrying capacity of the micelles and residual vesicle is exceeded. At this point, bile is supersaturated with cholesterol and cholesterol monohydrate crystals may form. Thus, the main factor that determine whether cholesterol gallstones will form are first, the amount of cholesterol secreted by liver cells relative to lecithin and bile salt, and second, the degree of concentration and extent of stasis of bile in the gallbladder. Next, calcium, bilirubin, and pigment gallstones. Bilirubin, a yellow pigment derived from the breakdown of heme and actively secreted into bile by liver cells. Most of the bilirubin is in the form of glucuronidase conjugates, which are water-soluble and stable, but a small proportion consists of unconjugated bilirubin. Unconjugated bilirubin, like fatty acids, phosphatate, carbonate, and other anions, tend to form insoluble precipitate with calcium. Calcium enters bile passively along with other electrolytes. In situations of high heme turnover, such as chronic hemolysis or cirrhosis, unconjugated bilirubin may be present in bile at higher than normal concentrations. Calcium bilirubinate may then crystallize from the solution and eventually form stones. Over time, various oxidation cause the bilirubin precipitate to take on a jet-black color, and stones formed in this manner are termed black pigment gallstones. Black pigment stones represent 10–20% of gallstones. Bile is normally sterile, but in some unusual circumstances, it may become colonized with bacteria. The bacteria hydrolyze conjugated bilirubin, and resulting increase in unconjugated bilirubin may lead to precipitation of calcium bilirubinate crystals. Bacteria also hydrolyze lecithin to release fatty acids, which also may bind calcium and precipitate from the solution. The resulting concretion have a clay-like consistency and are termed brown pigment stones. Unlike cholesterol or black pigment gallstones, which form almost exclusively in the gallbladder, brown pigment gallstone often forms the de novo in the bile ducts. And about mixed gallstones, cholesterol gallstones may become colonized with bacteria and can elicit gallbladder mucosal inflammation. Lytic enzymes from the bacteria and leukocytes hydrolyze bilirubin conjugates and fatty acids. As a result, over time, cholesterol stones may accumulate a substantial proportion of calcium bilirubinate and other calcium salts, producing mixed gallstones. Large stones may develop a surface rim of calcium resembling an eggshell that may be visual or on plain X-ray films. And gallstone disease may be thought of as having the following four stages. And first, the lithogenic state in which conditions favor gallstone formation. Second, asymptomatic gallstones. Third, symptomatic gallstones characterized by episode of biliary colic. And last or fourth, complicated cholelithiasis. Symptoms and complications of gallstone disease result from effects occurring within the gallbladder or from stones that escape the gallbladder to lodge in the common bile duct. And about asymptomatic gallstones, gallstones may be present in the gallbladder for decades without causing symptoms or complications. In patients with asymptomatic gallstones discovered incidentally, the likelihood of developing symptoms or complication in 1–2% per year. In most cases, asymptomatic gallstones do not require any treatment. And about biliary colic. Pain turned biliary colic occurs the gallstones or sludge fortuitously impact in the cystic duct during a gallbladder contraction, increasing gallbladder wall tension. In most cases, the pain resolves over 30 to 90 minutes as the gallbladder relaxes and the obstruction is relieved. Episodes of biliary colic are sporadic and unpredictable. The patient localizes the pain to the epigastrium or right upper quadrant and may describe radiation to the right scapular tip. The pain begins postprandially, is often described as intense and dull, and may last from 5 hours. From onset, the pain increases steadily over about 10 to 20 minutes and then gradually warms when the gallbladder stops contracting and the stone falls back into the gallbladder. The pain is constant in nature and is not relieved by enzymes, antacids, defecation, flatus, or positional changes. It may be accompanied by diaphoresis, nausea, and vomiting. Other symptoms often associated with cholecystitis include indigestion, dyspepsia, belching, bloating, and fat intolerance. However, these are very non-specific and occur in similar frequencies in individuals with and without gallstones. Cholecystectomy has not been shown to improve these symptoms. And what about uncomplicated biliary colic pain that is poorly localized and visceral and essentially benign abdominal examination without rebound and guarding absence of fever. And acute cholecystitis, well-localized pain is the right upper quadrant, usually with rebound and guarding, positive Murphy sign, frequent presence of fever, absence of perinatal signs, frequent presence of tachycardia and diaphoresis. In severe cases, absent or hypoactive bowel sound. And what about examination and abdominal radiography? Used primarily to exclude other causes of abdominal pain, intestinal obstruction. Black pigment or mixed gallstones may contain sufficient calcium to appear radiopaque on plain film. The finding of air in the bile duct or plain film may indicate development of an choledoenteric fistula or ascending cholangitis with gas-forming organism. Calcification in the gallbladder wall is indicative of severe chronic cholecystitis. The main role of plain film in evaluating patients with suspected gallstone disease is to exclude other causes of acute abdominal pain, such as intestinal obstruction, visceral perforation, renal stones, or chronic calcific pancreatitis. Cholecystography. The following symptoms are characteristic for patients with chronic cholecystitis. Absence of gallbladder shadow, deregimes of concentration, ability and motility of gallbladder, and deformation of gallbladder wall. Next, ultrasonography, the procedure of choice in suspected gallbladder or biliary disease. It is the most sensitive, specific, non-invasive and inexpensive test for the detection of gallstones. It is highly sensitive and specific for gallstones greater than 2 millimeters. It is less so for microlithiasis or biliary sludge. Ultrasonography is very useful for diagnosis uncomplicated acute cholecystitis. The sonographic feature of acute cholecystitis include gallbladder wall thickening, polycystic fluid, gallbladder distension, and a sonographic Murphy sign. The presence of multiple criteria increases its diagnostic accuracy. Endoscopic ultrasonography, an accurate and relatively non-invasive means of identified stones in the distal common bile duct. And ultrasonographic criteria of inflammation in gallbladder. Thickness or wall of gallbladder more than 4 millimeters in the absence of liver and kidney pathology and congestive heart failure. Increase of gallbladder size over 5 cm above the normal for the corresponding age. Presence of sonographic Murphy sign, presence of parasitic hypoechogenic limbus. Next, CT or computed tomography imaging, more expensive and less sensitive than ultrasonography for detecting gallbladder stones, but superior for demonstrated stone in the distal common bile duct. Magnetic resonance imaging with magnetic resonance cholangiopancreatography usually reserved for cases in which cholecystitis is suspected, and scintigraphy highly accurate for the diagnosis of cystic duct obstruction. And about endoscopic retrograde cholangiopatography is usually performed in conjunction with endoscopic retrograde sphincterotomy and gallstone extraction. And what about differential diagnosis? There are other common medical conditions that can mimic the presentation of chronic cholecystitis, through analysis of the clinical presentation offer can guide appropriate workup. Common clinical features of these disorders are as follows: acute cholecystitis, gallbladder cancer, peptic ulcer disease, gastroesophageal reflux disease, gastric cancer, myocardial infarction, mesenteric ischemia, and mesenteric vasculitis. And next part of this lecture, treatment. Treatment of cholecystitis depend on the severity of the condition and the presence or absence complications. Uncomplicated cases can often be treated on an outpatient basis, and antibiotics may be given to manage infection. And treatment phase of exacerbation. Antibiotics. Indication for antibiotics therapy maybe presents all clinical or laboratory signs of inflammation, positive result of bile culture, and cholangitis. And what to use? Ciprofloxacin 500 mg to a day per dose, course 5 days. Cefotaxime 1 gram to a day intramuscular. Doxycycline 100 mg to a day per dose, course 5 days. Amoxicillin 500 mg 3-4 times a day. Tinizadol 4 pills per dose once. Next step in treatment, symptomatic therapy. Prokinetic agents, domperidone 10 mg or etaprit 50 mg 3 a day, 30 minutes prior to meals. Next, spasmolytics, mebevirin 200 mg 2 a day, course 3-4 weeks. Trotavirin 40 mg 3 a day before meals. Papavirin 2% 2 ml intramuscular. Next, bile expelling medication, preparations that stimulate holopoietic function of liver. And for example, preparation of bile acid, coenzyme liobilum, synthetic preparation, oxphenamine cyclovalol, preparation of herbal origin, straw flower extract, peppermint extract, corn stigmas, and preparation that improves secretion of bile by increasing of its aqueous component, mineral waters, and preparations that stimulate biliary extraction, polykinetics, xylite, sorbate, magnesium sulfate, and cholecystitis. Next step, UDSA 8-10 milligram on kilogram a day, and herbal hepatoprotectors with bile expelling properties. And treatment during phase of remission. Diet meals 5-6 times a day, exclude fatty, spicy, smoked food, pickles and alcohol, phytotherapy, mineral water, physiotherapy and exercise therapy. Treatment of asymptomatic gallstones. Surgical treatment of asymptomatic gallstones without medically complicated diseases is discouraged. The risk of complication arising from intervention is higher than the risk of symptomatic disease. Approximately 25% of patients with asymptomatic gallstones develop symptoms within 10 years. However, cholecystectomy for asymptomatic gallstones may be indicated in the following patients. Patients with large gallstones greater than 2 cm in diameter, patients with non-functional or calcified gallbladder observed of imaging studies and who are the risk of gallbladder carcinoma. Patient with spinal cord injuries or sensory neuropathies affecting the abdomen. Patient with sickle cell anemia in whom the distinction between painful crisis and cholecystitis may be difficult. And patient with risk factor for complication of gallstones may be offered elective cholecystectomy, even if they have asymptomatic gallstones. These groups include persons with the following condition and demographics: cirrhosis, portal hypertension, transplant candidates, and diabetes with minor symptoms. And medical dissolution of gallstones. In patients with established cholesterol gallstones, treatment with ursodeoxycholic acid as a dose of 8-10 mg on kilogram a day divided BT may result in gradual gallstone dissolution. This intervention typically requires 6-18 months and is successful only with small, poorly cholesterol stones. Patient remain at risk for gallstone complication until dissolution is complicated. The recurrence rate is 50% within 5 years. Moreover, after discontinuation of treatment, most patients form new gallstones over the subsequent 5-10 years. And treatment of patient with symptomatic gallstones. A patient with symptomatic gallstones discuss the options for surgical intervention. Surgical interventions to be considered include the following: cholecystectomy, cholecystostomy, and endoscopic sphincterotomy. Oral bile acids used for the dissolution of gallstones include cyanodeoxycholic acid and ursodeoxycholic acid. Oral bile acids are most effective for small gallstones and may take up to 24 months to clear the stones. Ursodeol is the most commonly used oral bile acid, secondary to its safer sites effect profile via this cyanodiol. Cyanodiol is associated with dose-dependent diarrhea as well as hepatotoxicity, hypercholesterolemia, and leukopenia, all of which limit its use. And about choledocholithiasis. Choledocholithiasis is the presence of stones within the common bile duct. It is estimated these common bile duct stones are present in anywhere from 1–15% of patients with choledocholithiasis. Choledocholithiasis can be found in 4 and 6% to 18 and 8% of patients undergoing cholecystectomy. Choledocholithiasis occurs as a result of either the formation of stones in the common bile duct or the passage of gallstones that are formed in the gallbladder into the common bile duct. Bile stasis, bacteria, chemical imbalances, increased bilirubin excretion, pH imbalances, and the formation of sludge are some of the factors which lead to the formation of these stones. Less commonly, stones are formed in the intrahepatic biliary tree, termed primary hepatolithiasis, and may lead to choledocholithiasis. Stones that are too large to pass through the ampulla of water remain in the distal common bile duct, causing obstructive jaundice that may lead to pancreatitis, hepatitis, and cholangitis. Primary calculi arising de novo in the duct are usually brown pigment stones developing in patients with hepatobiliary parasitism or chronic recurrent cholangitis, congenital anomalies of the bile duct, dilated sclerosite of stricture duct, and MDR 3-gene defect leading to impaired biliary phospholipid secretion. Choledocholithiasis is more common in female patients, pregnant patients, older patients, and those with high serum lipid levels. Cholesterol stones are typically found in obese patients with low physical activity or patients that have recently intentionally lost weight. Black pigment stones are found in patients with cirrhosis, patients receive total parenteral nutrition, and in those who have undergone a ileal resection. Nucleating factors such as bacteria are the source of the brown pigment primary common bile duct stone. Bile made in the liver and stores in the gallbladder can lead to gallstone formation. In some patients with gallstones, the stones will pass from the gallbladder in the cystic duct and then in the common bile duct. Most of the cholecystitis cases are secondary to the gallstones passage from the gallbladder into the common bile duct. Primary cholecystitis, which is the formation of stone within the common bile duct, is seen less commonly. Primary cholecystitis occurs in the setting of bile stasis with result in intraductal stone formation. The size of the bile duct increases with age. Older adults with dilated bile ducts and biliary diverticular are at risk for the formation of primary bile duct stones. Less common sources of cholecystitis include complicated Mirizi syndrome of hepatolytiasis. Doctor should examine the patient with particular attention to the general appearance, skin, vital signs, and abdomen. Tenderness is noted in the right upper quadrant of the abdomen. Systemic signs such as fever, hypertension, and flushed skin, if present, is indicative of infection or sepsis. Courvoisier sign is the presence of palpable gallbladder of the exam and is seen then gallbladder dilation evolved due to the obstruction of the common bile duct. The pain is colicky, located in the right upper quadrant of the abdomen and moderate in severity. That pain is intermittent and recurrent. Often patients will endorse a history of episodes of epigastric right upper quadrant pain or epigastric pain. A thorough review of system will reveal that the patient may have noticed a yellowing of his eyes or skin, experienced pruritus, and possibly nausea or vomiting. Jaundice occurs when the stones obstruct the common bile duct and conjugated bilirubin enters the bloodstream. A history included clay-colored stools and urine turning tea-colored is found in such patients. Jaundice can occur in episodes. A patient with cholangitis also may have a fever, chills, and possible altered mental status. Gallstones are responsible for approximately half of all cases of pancreatitis. Pancreatitis is precipitated when common bile duct obstruction is at the level of the ampulla of water. Pancreatic pain is located in the epigastric and mid-abdominal area and is continuous and radiated to the back. Nausea and vomiting are also present. Some patients have intermittent pain which result due to transient blockage within the common bile duct. Doctors should order a white blood cells count, hemoglobin, hematocrit, platelet count, total bilirubin, direct bilirubin, alkaline phosphatate, aspartate aminotransferase, and alanine aminotransferase. A transabdominal ultrasound is the first test that should be ordered for the patient suspected of any biliary disease, including cholecystitis. Endoscopic ultrasound as also can be used to identify suspected cholecystitis, but is more invasive than a transabdominal ultrasound of MRI or computer tomography. Although diagnostic endoscopic retrograde cholangiopancreatography is more sensitive, it is no longer routinely performed given the approximately 10% risk for post-procedure pancreatitis. If a patient is undergoing laparoscopic or open cholecystectomy, an intraoperative cholangiogram also can be performed to assess cholecystitis. It is performed by inserting a catheter in the cystic duct followed by injection of contrast material, which outlines the biliary tree. Film are taken to assess for the presence of filling defects and the flow of contrast into the duodenum. Intraoperative ultrasound or laparoscopic ultrasound will also identify cholecystitis. A transabdominal ultrasound is the first test that should be ordered to the patient suspected of any biliary disease, including cholecystitis. In most cases, an abdominal ultrasound will show a dilated common bile duct and stones within the common bile duct. The detection of common bile duct stones is typically impeded by the presence of gas in the duodenum, but ultrasound can identify common bile duct dilatation accurately with up to 90% accuracy. If a strong suspicion still exists based on history, physical and laboratory findings in the face of negative ultrasound, then a magnetic resonance cholangiopancreatography can be ordered. The treatment for cholecystitis is removal of the obstructing stones via endoscopic means. An endoscopic retrograde cholangiopancreatography can be performed under general anesthesia with the patient in ASF-prone, left lateral or supine position. Through prone is the most common position used. The endoscopist will then place a duodenoscope into the second portion of duodenum and advance a catheter and a guide wire into the common bile duct. A sphincterotomy then is used to cut the papilla using cautery and enlarge the ampulla of water. Often the stones will be released with this maneuver. A balloon catheter also can be used to sweep the common bile duct to remove any stones. The endoscopist also can place a stent in the common bile duct, which will serve two purposes. First, any remaining stones will be softened and potentially easier to remove with a second and retrograde cholangiopancreatography. Second, the stent will allow bile drainage to occur, preventing obstructive jaundice. If the stones are large, stuck, or there are many stones within the biliary tree, surgical removal is indicated. There are no medications that will cure cholecystitis. However, a one-time dose of 50 mg to 100 mg rectal indomethacin can be used to prevent post-procedure pancreatitis. Antibiotics are typically not needed for cholecystitis unless patients also have associated cholecystitis or cholangitis. And next part of this lecture, functional biliary disorders. What is biliary dyskinesia? Biliary dyskinesia is an enigmatic but important condition to consider in the evaluation of patients with right upper quadrant pain. Through history, workup and examination are needed, and this diagnosis is primary diagnosis of exclusion. Proper selection of patient for cholecystectomy is essential in order to avoid unnecessary operative intervention. What is biliary dyskinesia? Biliary dyskinesia is an asymptomatic functional disorder of the gallbladder whose precise etiology is unknown. It may be due to metabolic disorders that affect the motility of the gastrointestinal tract, including the gallbladder, or to a primary alteration in the motility of the gallbladder itself. Biliary dyskinesia presents with a symptom complex that is similar to those with biliary colic. And what are the symptoms biliary dyskinesia? Biliary dyskinesia presents with a symptoms complex that is similar to those with biliary colic. Episodes of right upper quadrant pain, severe pain that limits activities of daily living, nausea associated with episode of pain. And how is it diagnosed? In order to diagnose biliary dyskinesia, the patient should have right upper quadrant pains similar to biliary colic, but have a normal ultrasound examination of the gallbladder. For patients who are suspected to have biliary dyskinesia, the third diagnostic criteria for functional gallbladder disorders should be considered. And these include pain episodes that last longer than 30 minutes, recurrent symptoms that occur in variable intervals, pain that is severe enough to interrupt daily activity, pain that builds up to steady level, pain that is not relieved by bowel movements or postural change of anticides. Exclusion of other structural diseases that could explain these symptoms. Other supportive criteria include association of pain with nausea and vomiting, radiation of the pain to the infrascapular region, and pain that wakes the patient in the middle of the night, and normal liver enzymes, conjugated bilirubin, and amylase or amylolipase. If a patient meets these criteria and has a normal ultrasound examination, hepatobiliary aminodeacetic acid scan should be considered. Recently updated criteria for the performance of hepatobiliary scintigraphy should be followed to determine the gallbladder and ejection fraction. This guidelines recommended imaging and cholecystokinin octapeptide infusion as a slow and constant rate over 60 minutes. Also included are important clinical considerations prior to testing. Performance of the test only on an outpatient basis, no opiates for 4.5 of the drug or 6 hours prior to the study, and withholding other drugs with effect gallbladder motility including calcium channel blocker, octreotide, progesterone, indomethacin, theophylline, benzodiazepines, and H2 blockers. And hepatobiliary aminodeacetic acid scan is an imaging procedure used to diagnose problem of the liver, gallbladder, and bile duct, also known as cholecystography and hepatobiliary scintigraphy. And who should have a cholecystectomy? Patients who have episodes of biliary type right upper quadrant pain without structural abnormalities by ultrasound and an abnormal hepatobiliary aminodeacetic acid scan should be considered for cholecystectomy. Abnormal ejection fraction is considered to be less than 38% when the test is administered according to the guidelines described above. Some authors and experts recommended that the symptoms complex should also be a sufficient duration, at least 3 months before considering cholecystectomy. And that's all for today. Thank you for your attention, and if you have question, please leave your comment, and if you don't have question, see you on next Thursday at 12 o'clock. Goodbye.